Welcome, everyone. My name's Dr. Rob Murphy. I'm the Executive Director here at the Havey Institute for Global Health and the John Philip Fair Professor of Infectious Diseases and Professor of Biomedical Engineering here at Northwestern. Thank you for taking the time to join us this afternoon for our latest installment of the Havey Institute for Global Health Institute's seminar series, hosted in partnership with the Center for Global Pediatric Health. The title today is Updates in Pediatric HIV, Where Are We Now? Please take a moment to follow us on LinkedIn and Facebook, as well as Blue Sky and Instagram at hashtag FSM Global Health. In addition, we welcome you to become an Institute member to receive access to special resources and services that support research infrastructure. And for more information, you can visit our website, very simple one, globalhealth.northwestern.edu/members. The Havey Institute for Global Health and the Center for Global Pediatric Health are thrilled to host our center co-director, Sahera Fargo, at today's seminar. Sahera Fargo is an attending physician in infectious disease at the Ann and Robert H. Lurie Children's Hospital here in Chicago, as well as the co-director for the Center for Global Pediatric Health, which is part of the Havey Institute for Global Health. She obtained her DO at the University of New England and completed a pediatrics residency at Phoenix Children's Hospital. She spent a year working as a Pediatric AIDS Corps physician for the Baylor International Pediatric AIDS Initiative in Malawi. She also trained in infectious diseases at the Children's National Medical Center in Washington, D.C. Sahera is a translational investigator whose research portfolio focuses on complications of HIV children and youth in the U.S. and sub-Saharan Africa. She is also the principal investigator on multiple NIH-funded studies in the United States and Africa, focusing on a better understanding of the long-term health outcomes and chronic comorbidities associated with HIV in adults and children. She specializes in providing HIV care and treatment to infants, children, and adolescents, both living with and exposed to HIV, as well as all aspects of pediatric infectious diseases. Welcome, Sahera. We look forward to your presentation. And for the audience, we ask you, if you have any questions, to put them in the Q&A box in the bottom right hand of your screen. Then I will read the questions to Sahera and she can answer them. And you can put those questions in at any time during the presentation. And now, Dr. Fargo, I turn it over to you. We look forward to hearing your presentation, and thank you very much for joining us today.
Thank you. Thank you for the kind introduction. I'm going to share my screen here. So just bear with me for a second.
If you could put it in present. There you go. Great.
Okay.
Thank you.
Perfect.
Yeah. We see it and we hear you.
So no conflicts of interest. So I just want to get started right off the bat, since the title is Pediatric HIV, Where Are We Now? Let's talk about where we are. I think this audience is very familiar with where the burden of the incidence and prevalence for HIV in general, and similarly to what we know in terms of adults, the bulk of children living with HIV reside in Eastern and Sub-Saharan Africa. So there's a couple of numbers that I want to bring your attention to. The first one is that it's estimated that there's about 2.5 million children under the age of 15 living with HIV currently. And another kind of more staggering statistics is that it's estimated that about 14 million children under the age of 18 are either single or double orphans due to the AIDS epidemic. And so let's talk about where we are now and how far we've come and how far we still have to go. So if we think about, mostly what I want to focus this talk on is HIV that's perinatally acquired. So if you look at this graph, these are all from UNAIDS 2025 estimates. On the x-axis are the years. On the left are maternal ART coverage, and on the left is perinatal transmission rate. You can see that as the ART coverage has gone up over the last decade and a half or so, fortunately, perinatal transmission has gone down. However, really, maternal ART coverage since 2024, since 2019 really hasn't changed. We're kind of at the top 80%. And there's been a large decrease in perinatal transmission since 2010. But in 2024, 1 in 10 infants were still acquiring HIV infection through perinatal transmission. So we've come a long way, but we are kind of at a point where we've been stagnant. So let's talk about how and where in the perinatal transmission these infections are happening. So on the left are really kind of global numbers, and then it's broken up by Eastern and Southern Africa and Western and Central Africa. On the blue are mothers who are on ART but not suppressed. On the green are women who did not continue antiretroviral therapy during pregnancy. In yellow are mothers who never received ART, and in orange are mothers who acquired HIV during pregnancy and breastfeeding. And you can see in Eastern and Southern Africa, a third of new pediatric HIV are attributable to women who are acquiring HIV during pregnancy. And then in Western and Central Africa, the bulk of the infections are because mom never received ART. So globally, of the 58,000 new children infection, nearly half of them are either because mom are not diagnosed or are not on ART. So again, we've come a long way, but we're not quite there in terms of catching every moms to prevent perinatal transmission of HIV. So once these infants are I've acquired HIV and are perinatally transmitted, let's look at the breakdown by sex, which I think is really important, especially for us as a Global Health Institute to understand. So in blue are HIV in adolescent boys and young men. In orange are adolescent girls and young women. And you can really see that other than in Western and Eastern and Southern Africa, the bulk of the regions, men are really predominantly acquiring HIV. And then really in sub-Saharan Africa, it's the majority of the women. So globally, 57% are adolescent girls and young women versus 43% are boy. And so when we think about HIV testing and treatment cascade by age and sex from the last year. So these graphs are broken up by kind of the 90-90-90, which some of us may be familiar with. So the goal, the Millennium Development Goal was that 90% of people with HIV would know their status. 90% of them would be on ART, and 90% of those on ART would be virally suppressed. So when we look at where we are in terms of children 0 to 14 years, we often think of these metrics are being quite successful, especially for the first 90 globally in terms of people knowing their HIV status. And you can see that's clearly not the case for pediatrics. So only roughly around 60% of kids who are living with HIV know their status. 50% of them are on ART, and less than 50% of them are also virally suppressed. And then when you look at it broken up by sex, women tend to fare a little bit better than men. So adult men are lagging behind adult women. So how did this how did this start, and how did I become interested in perinatally acquired HIV? So as Dr. Murphy mentioned, I worked in Malawi a decade and a half ago now, really kind of at the peak of the HIV epidemic. And our job was really to go on the wards, and this is the malnutrition ward with one of my colleagues, to try and diagnose. Diagnosis was not routine. It was not routinely offered, especially in the malnutrition ward. And as you can imagine, the prevalence of HIV in that ward was really staggering. And then the next kind of job was to really try to spread throughout the country the PMTCT guideline. And this was at a time when we were still just giving the single dose nevirapine and not testing all the moms, but you can see them here lining up to be tested, or in some case to continue to receive their ART for themselves and their children. So we've come a long way. You know, the past goal, especially for perinatally acquired HIV, was to keep these kids alive, despite some not so great statistics that I've given you for the past few slides. Again, HIV-related deaths have increased for all ages, including for children between the ages of 0 to 14. So there's been an 80% decline in deaths from the peak in the early 2000s. And then again, we've come a long way, but since 2023, we're a little bit stagnant. So our role now as a pediatric HIV infectious disease and practitioner is really to ensure that these children are virally suppressed. have great immune recovery. So the sooner we start, the best it is to in terms of achieving the highest CD4 cell count possible. And then almost everybody worldwide, and almost regardless of age, are on a single pill once a day. And that's really incredible. And it's almost homogeneous in terms of what children are receiving, both here in the US or global north, and then in the global south. Almost everybody now is on an integrase or contemporary ART regimen. And I'll talk about injectables in a little bit, but you may know now we have twice monthly or every 2 months injectable for ART treatment. And just recently approved by the FDA, we have an injectable that we can give every 6 months for PrEP or prevention. So we've come a long way, and now we're kind of at the intersection of HIV being not only an infectious disease, but also we're managing comorbidities. So we have that double burden of infectious disease and non-communicable disease for those who are living with HIV. So as I mentioned, we've done a great deal for health span, but not so much for health span. So what do I mean by that? In this graph, again, on the x-axis are the years, and you'll see in blue here are really kind of morbidity. Sorry, the circles are adults living without HIV. The triangles are those living with HIV. So mortality has decreased. But it's not quite meeting those without HIV. And then in orange, really that increased lifespan, as you can see with those in HIV, again, with the orange triangle, come at a certain cost. And so it's thought that on average, adults living with HIV live 9 to 15 fewer healthy years, so comorbidity free, compared to those living without HIV. So we've done a lot in terms of increasing their life, but not necessarily a life without comorbidity. And so that's thought to be due to accelerated or premature aging. And aging happens, right, regardless of whether we want it or not, at all ages. But it's hypothesized that this accelerated aging can also happen in children. So what do I mean by that? This is an algorithm from the FAAP study that's been adapted from biomedicine, where you can see chronological age on the x-axis and biological age on the y-axis. You see in blue, this is the general aging process for the general population. And so the model hypothesized that when you acquire HIV, aging is accelerated, and that's dampened a bit by starting ART, but it does not fully recover the trajectory that we would expect for those living without HIV. And so what I'm hoping to do in the next kind of 40 minutes or so is to talk to you about the clinical implications of premature aging that happen in youth with perinatally acquired HIV. That's what PHIV stands for throughout these slides. Talk a little bit about the mechanisms of these complications, and then the strategies that we have at our disposal to mitigate them. And so what our group is interested in is, are youth with PHIV at risk of comorbidities that we're seeing in adults with HIV? And mainly we have focused on cardiometabolic complication, because we know that cardiac disease is the #1 cause of mortality in HIV, really worldwide. And then what we want to see is, other than cardiometabolic complications, are there other things we should be concerned and measuring, and what's feasible in a resource-limited setting? So I've been fortunate, as I mentioned, I worked in Malawi in the early 2000s. And since 2016, we've developed a cohort of youth with perinatally acquired HIV and age and sex match uninfected youth in Kampala, Uganda, the Joint Clinical Research Center. These pictures highlight our team, some of the modalities that we've used to measure cardiometabolic complication. And then at the bottom here is one of our first participants that we enrolled. And so how do we measure cardiometabolic complications? So our group and others have really focused on what precedes cardiovascular disease in adults, and that's prediabetes, dyslipidemia, truncal fat or visceral fat, which we know is associated with increased CVD risk, and then adipose tissue dysfunction. So it doesn't just matter where the fat lies, but the type of fat and its pathophysiology is also really important. So this is kind of a snapshot of our cohort. Currently, this was in the last year. Median age, you can see 16. Roughly half of the participants are female. Now, almost all of them are post-pubertal. When we look at socioeconomic variables, you can see being HIV is slightly more likely to be associated with economic insecurity and lack of electricity, but roughly both youth with and without HIV are similar when we look at socioeconomic variables. And then by design, all of those with HIV are virally suppressed or have an undetectable viral load. At 16 years of age, they've already seen more than a decade of being on ART. And then the current ART regimen that they're on is pretty standard based on the WHO guideline of tenofovir, lamivudine, and dolutegravir. So kind of the first thing we wanted to look at is we took these kids, both those with and without HIV, and we put them through a DEXA to measure their body composition. We measured their insulin and glucose, their lipids, and then biomarkers of systemic inflammation and gut integrity and translocation. And I'll get to the gut part a little bit further down the talk. But what we found is that the kids really kind of clustered around a phenotype that was concerning for higher cardiovascular disease and future cardiometabolic risks. So if we focus on kind of this blue cluster here, you can see that the majority of these kids were more likely to have increased total body fat, increased truncal fat, higher waist to hip ratio. All of their biomarkers pretty much were elevated when we look at systemic inflammation, such as CRP, monocyte activation like soluble CD14 and 163. And then two factors that we didn't include in this clustering analysis was insulin resistance and sex. And you can see just by doing this cluster analysis, the participants clustered also with prediabetes and more likely to be female. So really this cluster one, female, although not significant, but more likely to be living with HIV, teenage girls have this phenotype that seems to be concerning for future risk of cardiovascular disease. So then how do we measure kind of predisposal? So not only just the metabolic factors, but evidence of future cardiovascular disease really at a cardiac standpoint. So there's two methods that we use. One, to measure subclinical vascular disease, we use carotid ultrasound or the intima media thickness, which in adults without HIV has been shown to be associated with future risk of heart attack and stroke. And then we also measured endothelial dysfunction, which really precedes all sorts of cardiovascular disease, using this machine called EndoPAT, and it's the PAT stands for peripheral artery tonometry. So it's just a probe you put on the finger and you inflate a blood pressure cuff and measure pre and post the hyperemic index, and that gives you an indication of the health of the endothelial cells. So when you look at data kind of captured in youth with perinatally acquired HIV and without HIV, you can see that studies that have measured the subclinical vascular disease using IMT are really predominantly in the global north. And then our studies listed here in Uganda. And most of these studies have found a slightly significant, although small difference in the intima media thickness when comparing those with and without HIV. And you may say, like, is 0.05 millimeter really that clinically meaningful? Well, it appears that in adult studies, a 0.1 millimeter IMT difference is associated with an increased risk of myocardial infarction and stroke. And so we're seeing all those small differences, but at a quite early age, that seems to indicate that these kids have evidence of subclinical vascular disease. So the other measure was the endothelial dysfunction using kind of that figure probe test. And we measured those in a study that I was involved both in Cape Town and also in Cleveland. And you can see in both cases, youth with perinatally acquired HIV have a low reactive hyperemic index, which we know is associated with endothelial dysfunction. Again, highlighting the point that at a young age, they seem to have evidence of future cardiovascular disease risk. And then when we think about adults that you may see in your clinic, we often can calculate the risk of future atherosclerotic event. which are not really applicable to children. So enter the PIDS score, or the pathobiological determination of atherosclerosis in youth. The PIDS score was a certain post-mortem in abdominal and aortic arteries in order to determine the future risk of atherosclerosis. So similarly to the AHA or ASCVD scores, points are acquired for the traditional risk factors such as non-HDL cholesterol, age, hypertension, male sex, obesity in males only, HDL cholesterol, and smoking. And there was a really large study of youth without HIV between the ages of 18 and 30. And a PIDS score greater than 1 was associated with atherosclerosis progression 25 years later, and could lead in an increased rate of myocardial infarction for some of these young adults. And so in studies both done in the US through the FAAP cohort study, which is an observational study, both in the US and in Puerto Rico, and in CTAC, that Cape Town study, 30 to 48% of youth with perinatally acquired HIV have a PIDS score equal to or greater than 1, again, indicating their future risk of atherosclerosis. And so these complications, unfortunately, don't live in a vacuum, and we have a tendency to see kind of a syndemic of comorbidities. So youth with PHIV are at risk of multi-system impairment. This study was done again in South Africa and Cape Town, comparing youth with and without HIV. And what they found is that those with HIV are more likely to have more than one system involved, specifically the cardiac and neurocognitive domains, as you can see in this table. And so we asked the same question. We found kids with a certain phenotype at risk for cardiometabolic complication. Could those kids also be at risk of neurocognitive impairment? So we partnered up with a group at Columbia University led by PI Ruben Robbins. He and his team developed a tablet-based app that could really be done offline, so really easy for us in a setting where internet is not really reliable, and to be done easily by our study team that are not necessarily neuropsychologists, right? So they could be done rurally, and we've adapted this tablet to several languages, local languages in Uganda, and you can see Christine here is our study coordinator, and this is one of the first patients that we adapted this NeuroScreen tablet on. And so we wanted to really measure the incidence and prevalence of neurocognitive impairment in this cohort. And so you might recognize Caroline Carlson. She was one of the speakers at our Havey Institute Gala a couple of weeks ago. She's a third-year medical student. This is her research project that she'll be presenting at ID Week in a couple of weeks. But she looked at the different domain of neurocognition through this tablet-based app, and looked at differences after adjusting them and creating Z-scores in youth with and without HIV. So the purple in here are youth with HIV. And you can see that in almost all domains highlighted here, they score poorly and have lower attention deficit, processing speed, etc., when comparing to those without HIV. So we went ahead and adjusted her findings for age, gender, socioeconomic, so food and energy insecurity, and access to clean water. And you can see, despite some small differences in socioeconomic variables, the differences in neurocognition remained, and those with HIV were still scoring poorly. So additionally, Angel Neteza, she's a master's student that we've co-mentored for the last several years, started administrating the ACE and also the PHQ-9 questionnaire. And to her surprise, find around 14% of our participants had previous suicide attempts that were reported, which was really shocking to us because honestly, I was so focused on the cardiometabolic complications, right? Part of our initial questionnaires was not, have you previously had a suicide attempt? And so it was really shocking to see that these 14, 15-year-old already had previous suicide attempt, and that the rate was actually higher than what's been reported in Uganda previously. And you can see highlighted here, there are several adverse childhood events that were associated with previous suicide attempts. And so hopefully I've convinced you in kind of this first part that it appears that youth with PHIV, even at a young age, are at high risk of cardiometabolic complication, and appears that those don't just live in a vacuum, and then there might be a syndemic, especially with neurocognitive impairment, of other comorbidities that could coexist in this population. And so what are some of the mechanisms that may be associated with some of these complications that we know happen with premature aging? You know, it's a well-known fact that inflammation is associated with complication of aging in adults with HIV, and I've highlighted a few of the markers here that are well-known, not only with aging, but with mortality. And so what we don't really know, especially in the global south, is does that inflammation persist in youth despite contemporary ART and viral suppression? Is that inflammation associated with the complications that I've just shown you previously? And then are there other mechanisms of aging that we can detect in youth with HIV? So when we look at inflammation, what we did is we took that cohort and followed them for 2 years on ART while they were virally suppressed and measured different markers of systemic inflammation and immune activation. And what we found is that their gut markers and markers of poor barrier of gut integrity really remained elevated. And it's well known that the gut is really a sanctuary site for HIV and really kind of the first site that's attacked and never quite recover. And that's, again, what we see with these children is that they had higher markers of poor gut integrity and gut translocation. We did not see evidence of bacterial translocation. And the reason for that is at the time of the study, the guidelines, the WHO guidelines were that children had to be on Bactrim regardless of their WHO stage. So that makes sense. They were on antibiotics. Second, we see that despite viral suppression, they have ongoing markers of immune activation. So both the monocyte activation soluble CD14, but also cellularly patrolling monocytes that are known to be pro-inflammatory. And then lastly, and not surprisingly, we see ongoing T cell activation. And so our team really looked further to see if some of these markers were associated with complication. And I'm giving you just one example here with the marker soluble CD14. We found that almost all of the complications that are cardiometabolic that I showed you earlier in the talk were independently associated with the soluble CD14, which is also what we see in adult. And this marker soluble CD14 is a powerful predictor of morbidity and mortality in adults living with HIV. And so this leads me to our newer project, although we're in year 4 of the grant already, where we became more interested in that immune process. And our grant title Timing is really interested in trained immunity. So we think about immunity to vaccines or long-term immunity as really kind of the cellular immunity, T cells and B cells. We're more interested in looking at natural killer cells and monocytes and mitochondrial dysfunction. What's interesting with natural killer cells and monocytes is that how they modify over time is really through epigenetic modification and metabolic reprogramming, which we know is also kind of how the aging process happens. And so we're in year 4 and just about to analyze our longitudinal data to look at some of these NK and monocytes. But I'll just show you this cluster analysis real quick. Is we looked at genes that had a gene expression signature that are associated with trained immunity. And you can see this cluster analysis in dark blue. Our kids with HIV seem to have gene expression that are associated with ongoing trained and immunity. So it'll be interesting to see in future studies now that some of our samples are more longitudinal to see if that persists and what that means. So I talked about gut barrier dysfunction. Again, we find that over time, the gut barrier dysfunction persists and further fuels inflammation. And what we have found is that surrogate markers of gut integrity, right, because we're not taking colonic biopsy to really look at the gut lining, is associated with adipose tissue and visceral fat. It's associated with prediabetes or insulin resistance. It's associated with altered lipidome and subclinical vascular disease and neurocognitive impairment. So really kind of those gut markers seem to be really important, especially in kids who are already virally suppressed and on a contemporary ART regimen, and could be an interesting target for future interventions to mitigate these complications. And so hopefully this part of the talk, I've convinced you that inflammation persists in youth despite viral suppression, that inflammation appears to be associated with complications, and other mechanisms of aging, such as gut barrier dysfunctions, are seen in youth. So in the last part of my talk, I want to focus on the so what. So we've demonstrated this. We've demonstrated that they have evidence of premature aging. These kids are entering kind of the most productive years of life, right? A lot of them are aging towards young adult, are heading towards young adulthood. So what are some of the strategies that exist or that we have data about in terms of mitigating premature aging? So what's interesting is that we know risks of cardiovascular disease begins really early in life. There's plenty of data suggesting that prediabetes in teenage years lead to future disease, that being obese when you're a teenager or having adiposity more centrally is again associated with a higher risk of MI in future young adults. However, most randomized controlled trials focused on CVD prevention really don't exist under the age of 40 years. And we know that it's not just cardiometabolic complication, it's the entire environment that you live in, your community, your interpersonal relations, and really your individual risk factors that shape your CVD risks. But there is very few study looking at mitigating this risk early in youth and young adulthood. And so we talked about advanced aging, and as a pediatrician, it's weird to talk about geroscience and geroprotectors, but here we are. I think we all know that for healthy aging, the boring stuff like regular exercise, nutritious diet, social connections are important. And I would say not only just healthy aging, but healthy living in general. So we decided to look into these factors a little bit further to see if there was room for improvement in youth in Uganda. So I showed you this baseline table earlier on in my talk, and I want to focus on some of this diet and exercise. So we do a dietary diversity questionnaire, which is a little bit easier to do in our setting than a full food recall. And we've adapted the scoring system based on the World Food Program that's in Uganda. And you can see youth with HIV have a lower dietary diversity in terms of what they have access to on a daily basis. So that might be some room for improvement, especially when we talk about their gut barrier. And then when we looked at physical activity, so again, these are all subjective because they're questionnaires, but we ask them question in terms of their daily physical activity, whether they're walking, playing at recess, how are they getting to school, their chores that they're doing at home. And I'll interpret these numbers for you. On average, they have 3 hours of moderate activity per day, which is a little bit, and significantly higher than those without HIV. We're trying to tease this out and trying to see if we can have more objective measures, of physical activity, but they're walking everywhere, really is what we've discovered, is that even within Kampala, where they have access to like the motorcycle, the minibuses, they really are doing a lot of walking, especially to and from schools. And so I want to put this, everything is relative. So I want to give you kind of something else to compare this physical activity to. So these data are from the Pediatric HIV AIDS cohort study. As I mentioned, it was an observational cohort study in the US. And these are looking at youth with HIV in purple and youth who are exposed but uninfected. And so we looked at total energy expenditure, again, through block activity questionnaires and physical activity duration. And you can see that between the ages of 9 and 11, there's really kind of a decrease or stagnation in physical activity in youth with HIV. So again, this highlights the fact that You can't extrapolate data, especially when it comes to risk factors of comorbidities for youth or even adults with HIV. So we really need to prompt our teens here in the US to exercise. And I'm still trying to figure out how teens in Kampala fit 3 hours of moderate activity per day, but something to live by. So again, talking about what we know are geroprotectors, we talked about diet, we talk about physical activity. What about social connection? And in this case, we looked at adverse childhood events, which I mentioned when I talked about suicide risk. So this project is from Sarah Aljoni, who's a pediatric resident in Canada. And her project looked at adverse childhood events and how they correlated with some of the comorbidity and inflammatory measures that I mentioned. And what she found is, again, we like cluster analysis. So we did a cluster analysis and found that there was a cluster of kids who had higher adverse childhood events, especially neglect and abuse. And those kids were more likely to be living with HIV, more likely to have monocyte and T-cell activation, more likely to have high blood pressure and increased pulse wave velocity over 96 weeks, which is another measure of subclinical vascular disease. So, these findings are not surprising in the sense that even here in the US, we know that having an adverse childhood can correlate to heart disease in adulthood. But what's surprising is that these kids are only 14 to 15 years of age, and we're already seeing that adversity that they've had prior to the age of 10 are already translating to measures of increased cardiovascular disease risks. And so this is really kind of the focus of one of our newer grants, where we're looking to measure adversity and comorbidities. And so when we talk about mitigating complications of age, I think a lot of you in this audience are familiar with the REPRIEVE trial, which was a really large RCT enrolling adults with HIV who had moderate atherosclerosis risks. And this study randomized patients, adult patients, to 4 milligrams of statin versus placebo. And the study was terminated early at around a 5-year follow-up, because you can see that there was fewer major adverse cardiovascular disease events in the statin arm compared to the placebo arm. And this subsequently last year led to new guidelines for use of statins for people with HIV, and is really kind of groundbreaking in terms of prevention, especially for adults, because the inclusion age is 40 to 75. So what about statin for youth, right? What about a 35-year-old who's lived with perennially acquired HIV? And what the guidelines say is really there's just insufficient evidence to recommend it for people under the age of 40. And so this made me wonder, so why can't we do this study, and why can't we recommend them, and why isn't there the data to say that, yeah, a 30-year-old is also at risk of, as I've shown you, at risk of future increased cardiovascular disease rate. So there's several challenges. A is, as I've shown you, at 15, a lot of them have already seen ART for almost a decade. So they're starting ART at a critical period of immune development. They've been on longer ARTs, so a 40-year-old who was horizontally acquired versus a 35-year-old with perennially acquired transmission are really two different patients in front of you. They've been exposed to older, more toxic regimen. Fortunately, the patients that we see here in clinic, they don't have heart outcome, right? I haven't seen MIs or stroke in 20-year-old, thankfully. But it becomes harder to measure for studies like a randomized control trial to prevent future risk. There's, as I've shown you, there's differences in traditional risk factors and social determinants of health when we compare global north to global south. And then how do we contextualize these complications? So like that intima media thickness that I've shown you, what does that mean in terms of the clinical context, and how can that help our clinical practice? And so really those two factors that are highlighted in red, what does it mean? and it's really hard to reproduce pulse wave velocity. It takes a lot of people to measure IMT. We've trained several people who've gone on to, to move from the JCRC to different institutions. And so enters our recently funded Global Health Catalyzer titled Subclinical Assessment of Myocardial Fibrosis via MRI in Youth with Perinatally Acquired HIV. Our objective is to use cardiac MRI imaging to comprehensively measure myocardial dysfunction and vascular dysfunction in Ugandan PHIV. So the goal is to take 30 PHIV and 30 seronegative youth from the study that I've just described, put them through a cardiac MRI to try to measure cardiac fibrosis. To date, there's only one other study by Jennifer Howe, my colleague in Cape Town, that has measured subcardiac or myocardial fibrosis using MRI in youth with perinatally acquired HIV. And then given several of our studies that are really extensively measuring phenotypes of inflammation and immune activation, trying to figure out the mechanisms that are linked to myocardial fibrosis. And so not only are we hoping that this will help us scale up and find a more meaningful surrogate marker that's reproducible for future RCT. We're also hoping to streamline with Jennifer's study in Cape Town to kind of add that as a site for future intervention. But we're also hoping to build local research capacity. Kampala's just recently acquired in the last year and a half several MRIs. All of them are being really used for clinical purposes. The research really hasn't taken off yet. So we're hoping to build that capacity. And then additionally, we're hoping to use some to be innovative and to try to use AI in trying to reduce the MRI scanner time, but also to try to use AI paradigms. Some of them have been developed, some that we're hoping to develop, such as deep phenotyping of patients with to figure out who would be at risk for known or suspected risk of cardiovascular disease. And this could really be a game changer, especially in lower income settings like Uganda. So we met with a radiologist. As you can imagine, he's clearly very busy, like most of the clinicians that we work with. And so trying to figure out a way that we can have AI help in not only the scan time, but also the analysis would be really game changing. And then the last part of my talk, I figured I would address the elephant in the room, which is how the US government cuts have been affecting the work on the ground. And we've talked about this really in several of our Havey Institute meetings, but I wanted to address how the funding cuts has impacted already children living with HIV. So these are data from the Clinton Health Initiative that came out over the last few months. So in blue here, you can see are the numbers of kids who have started ART in the last quarter of 2024. And in pink is what's already gone down in the first quarter of 2025 by several countries. I didn't list what the countries are, but they're mostly Eastern and Sub-Saharan Africa. And you can see that in just a short quarter, there's already been a decrease in terms of new pediatric ART initiation. And then when we look at overall number of children in ART, you can see again, drastically, not drastically, but already having an impact on the ground. And so some of the response to the funding cliffs, I like this quote from the president of the International AIDS Society meetings, who said that really for the last 40 years, the HIV movement has faced a lot of adversity. This movement is no different. The HIV and the AIDS response really came from a crisis response, both in the US and in South Africa. I mean, Anthony Fauci gave many of podcasts kind of describing one of the AIDS Society meeting, I think in the late 90s, early 2000 in Durban, where there was a lot of advocacy and pushback. And so this is where we come from, and this is not something that we've shied away from. I think maybe some of you, hopefully we're able to join the 24 Hours to Save AIDS research. That was just a couple weeks ago, with investigators really worldwide pitching in and giving several talks for why saving AIDS research is important. And I would say that some of the advocacy has worked, both here in the US and abroad. One of the response to funding cliffs that I want to quickly touch on, and hopefully you heard in the news. So lenacapavir is the every 6 months injectable, so twice yearly injectable that was given for PrEP. This is the graph from the Purpose 2 study. So it compared HIV incidence rate to the background incidence and to the PrEP regimen that was already standard of care on the ground. And you can see with lenacapavir, there was no transmission, really zero infection. So lenacapavir was just approved by the FDA in June. And those 2 injections would cost around $30,000. I think it's between $28,000 to $30,000. Gilead has already given a bulk to be allocated to different countries through the Global Fund, free of charge. But what was really remarkable is last week, they've decided to partner with the Clinton Foundation and the Gates Foundation for these injectables to be at a cost of $40 per year, and also have some agreements with pharmaceutical companies in India to have generic formulation of lenacapavir. So this will be really a game changer in terms of decreasing new HIV transmission. So really, my last slide here, I hope I've convinced you that youth with perinatally acquired HIV have clinical evidence of advanced aging, have lifetime risk of cardiometabolic disease. They have ongoing immune dysfunction despite being virally suppressed and on regimen that are really kind of new and known to be great in terms of viral suppression. We've come a long way in increasing the lifespan, but we still need to do quite a lot to ensure that they age in a healthy manner, so health span, and that we really need future interventions to focus on not only screening, but diagnostic and therapeutic strategy. And so my last slide here, a big thank you to participants and their family. It truly takes a village. You know, people here at Lurie and Northwestern have been really supportive, and the team in Uganda, and then NIH, big thank you for our funding source. So I'll end here.
Sarah, thank you. Thank you so much. That was really a fantastic presentation. I invite anybody to put questions in the Q&A. We have one question so far, but feel free to add more. Thank you very much. Really fascinating findings so far. So Chad Achenbach says, how do levels of immune activation or inflammation differ between children with HIV in Africa compared to the US? And are chronic inflammation biomarkers higher in children in HIV in Africa due to co-infection, TB, parasites, malaria? Are there any other unique drivers?
Yeah, so that's a really good question, Chad. Actually, we just put in an abstract yesterday to CROI. Yeah, CROI submission is today, everybody. So we had samples from kids in the US with and without HIV, kids in Uganda with and without HIV, middle-aged adults and older adults. And so we looked throughout the lifespan, we all ran them together, did biomarkers of inflammation and Legend-Plex. And what's surprising is if you just look at HIV, actually almost everything is more inflamed in the US, which surprised us, especially in middle and older age adults. And so what's interesting is that remained even after we adjusted for co-infection. So the cohort per history, we ensure that they have no active malaria, no pneumonia, no diarrhea, no active TB. Again, it's by history in the last 3 months, but we have much higher rates. Everybody, regardless of the age, is CMV seropositive in Uganda compared to the US. It's about 40% of the US youth compared to 100% of the Ugandan youth. So even despite that, there were no big differences in Ugandan versus US youth. The Ugandans probably have higher chemokines, or when you look at soluble CD14, et cetera, there wasn't a big difference. But where we see differences really is like the older adults, and more in the US than Uganda. So thank you for that question. come to our poster.
Yeah, really. Do you think there's any other unique drivers involved here? Are you looking at any other
Yeah.
type of markers?
So, yeah, good question. Smoking rates are much higher in the US. And even after we adjust for that, it seems that differences persist. I'm curious to see, we looked at CMV seropositivity, but we didn't look at CMV viremia and viral load. So that's something we're interested in looking at. I'm also curious to see if there's differences by sex, because it seems that women in Uganda are much more inflamed than men, and the ones that have that like cardiometabolic phenotype that's at risk. So I don't know that answer yet. That's something we're digging into. And then so when we look at just markers of inflammation, there's no big differences, but definitely their gut barrier is much different.
And can you, so you're saying in the kids in Uganda, they have more physical activity?
Yeah,
I mean, it looked like a lot more compared
a
to
lot
US
more.
kids are slowing down.
Yeah, a lot more.
They're going up. Do you have like any kind of idea why that is?
Yeah. So, in general, and it's interesting because my colleague Chris Longenecker actually put a like accelerometer with like a little wristband to measure the physical activity in adults. And he saw that there really wasn't a lot of physical activity in Ugandan adults. But what I hypothesize is that the kids just walk everywhere. They walk everywhere. They walk to and from school, to the house that has solar panel and electricity. A lot of the kids don't have access to clean water, so they're responsible for the chores. So I wonder if that's where it comes from. And in general, our US kids are just, and US population, global north in general, we're sedentary, right? So
Yeah.
I wasn't surprised in seeing differences. I was just surprised in how.
But the US kids, that's matched to HIV negative kids.
Yeah. Yeah.
Yeah.
Yeah.
Okay, we got another question. Are there any other systems, lung, eye, kidney function, etc., that you may plan to investigate for a potential connection?
Yeah, that's a good question, Courtney.
Neuro, definitely, right?
Yeah, so neuro is the one, cardio and neuro are the two we've been focused on. Partnering up with Ryan Ross at Rush, because we got DEXA, but we didn't really look at bone metabolism. So that's one of the things that we're interested in. Pulmonary function, there's data from my colleague Angie Atia, who's in Washington, suggesting that kids with HIV have poorer pulmonary function. And I think she's compared Kenyan youth to US youth. But I think what we need to do is really look at the syndemics for organ system as a whole. And so, yes, the answer is yes.
Another question from Claudia Hawkins. Are you seeing any gender differences in inflammatory and metabolic markers in these kids, like we see in our own aging populations where women are greater than men, particularly?
METS, metabolic syndrome. Yeah, so one of the cluster analysis.
Sorry if I missed this, join later. Okay.
Yeah, no worries. We did a cluster analysis and it really clustered. It seems like the risk phenotype from an inflammatory and cardiometabolic complications really clusters around young female. And the same is true when you look like 40-year-olds. So it's interesting because when we looked when they were 10 to 14, there wasn't differences by sex for markers of inflammation, but those differences really are starting to show now that they're post-pubertal. So yes.
Okay. All right. We're pretty much at the top of the hour. If there are any other questions, please put it in now. Otherwise, I just have a few comments. Thank you, Sarah, for sharing your insight and giving us this really fantastic presentation today. I want to thank the audience for joining us, for asking your thoughtful questions. And we invite you to our next event, which in November. So this is the October event. The November event is actually Global Health Day, which is occurring on November 19th in the Lurie Medical Research Center. And we welcome keynote speaker Matthew Lawrence, MD, MPH, Professor of Pediatrics at the Center for Vaccine Development and Global Health at the University of Maryland. Dr. Lawrence will be presenting the keynote address, Vaccine Successes in Global Health. typhoid fever, and malaria. For more information, sign up for our newsletter and visit the Global Health Day website. Again, thank everybody for joining us today. A recording of the webinar will be available online and will be shared with via our newsletter. And so this concludes today's webinar. Thank you again, Sahera Fargo, for your wonderful presentation today. We certainly appreciate everything that you're doing.
Thank you.